It's absolutely a privilege to be out here presenting at the CVT meeting out here and to discuss this particular case of a challenging BTK angioplasty. And may I share with you that this is a intervention which was the first part of the intervention was done by you a couple of years back. So just to give you a surprise, and then the second part is basically.
I'm feeling exposed.
No, you did a great job. That's what I'm just saying. So this was a 65 years old male. He is a doctor from Saharanpur in India, who was a diabetic hypertensive CKD, but not on, he had deranged renal parameters with a coronary artery disease for which he had undergone angioplasty. He did undergo bilateral SFA stenting 2 years back in an outside hospital, which was basically Fortis Escorts. Dr. Atul Mathur had done, fixed his bilateral SFA and put in Supera stents in that one. And now he presented with, and after that, I think he was lost to follow up with Dr. Mathur also. And then in between, he was in another hospital and presented with non-healing wound over the right foot. So this is what he came across with a dirty, offensive-looking foot which was there, and that was very badly infected out there. You can see a couple, most of the toes are missing and very badly infected ulcer, which was basically Pseudomonas, which was resistant to every antibiotic. So when we examined him, we found that bilateral, the right and the left femoral and popliteal pulses was ++. So that's what I meant, that Dr. Mathur had fixed up this part very well. But bilaterally, the BTK pulses were absent. So both the anterior tibial, posterior tibial on both the sides were absent. And the duplex showed a calcific BTK disease involving all the 3 vessels. So our plan was to, address the affected limb, which was to consider doing a BTK angioplasty. And because of a pannus that he had, he was a little on the obese side. We prefer to do a crossover approach in these particular cases. And since his creat was also was on the higher side, we decided to use carbon dioxide angiography using our AngioDroid, which we have in our hybrid cath lab. So this is just to show you, this is the part which Dr. Mathur had done. This is beautifully patent. In fact, as you can see, the SFA is looking good out here. The stents were patent and looking absolutely pristine. But here, when you come out here, this is where the challenge comes, that he's got, out of the 3 vessels right now, you can see that only the peroneal is flowing through down below. The anterior tibial is occluded. The posterior tibial is again not visualized only, and I'll just run it a little further, and then maybe we can ask what would be the approach from other people. No, sorry, I just went across. This is something which happens. So I'll just let it run a little faster. So what we found was basically this was the part which was distally, I'm sorry, the stent 2. So we had a distal lesion. There was a tight lesion in the peroneal artery just above the ankle. And this is where we, thought that what should we do? We were not seeing, there's a little bit of a reformation of the anterior tibial artery at the ankle. And this is what the image is as we go along. And distal runoff, what you are seeing out here, peroneal stenosis, and you can see a faint ATA reformation out here. So if I can ask what would be the approach in this case, what would be our co-panelists and all, how would they think of approaching this lesion and all? You have a peroneal discrete stenosis out there, but unfortunately the peroneal part which is there, it's not really going across into the foot completely. So you're not seeing, although you are seeing the medial and lateral branches coming up and a gentle bit of the distal ATA, at the ankle opacifying. So what would be the approach, if I can ask in this case?
You want me to answer, Bedi sir?
Yeah, go ahead, Tarun.
So I think most of us in India, the usual practice is that in case we see a healthy heel, though the foot had some plantar abscess extending to forefoot, and as long as we feel that somehow we'll be able to give him a healthy hind foot, we are very aggressive in doing a BTK plasties in these patients. And whenever you have a vessel which is not crossing the ankle, we know unless until you increase the blood supply, it's not going to heal. So a
Yeah.
retrograde approach in these patients, though the reformation looks very poor, but sometime on a duplex guidance or on a fluoroscopic guidance, if we feel that the vessel is reasonably, I would say, accessible by a retrograde access, then with a micro puncture set and an 014 platform using a command wire with support catheters like Rubicon or something like Quick Cross. So these catheters can help in recanalization. Only challenge is that peroneal, like, if you have to just plasty the lower part, then we have to be just in and out because that's a single vessel. We don't want to spoil that. So
Absolutely.
yeah, so usually, and then be very aggressive with the debridement and adjuvants like a vacuum assisted closure, Integra, Dermacell, all these things can assist healing.
Fantastic. So you
Andrew,
laid
can I have
down,
your opinion in this? Would you like to unmute yourself?
yeah.
Yeah.
Thanks for asking for my opinion. We sadly see a lot of this in Singapore, actually, this very aggressive Belloni disease. I would echo what Dr. Tarun said. The only problem with the angio image is that we can't see the bones because of the projection. So obviously, we don't know exactly what's reconstituting where, because obviously sometimes with a formal angio run, you can see it a little bit better.
Yeah,
There's a couple of things
yeah.
I would probably add to it. Number one, we know that it's in the forefoot, and we know that there's going to need to be some extensive debridement. With the perineal not crossing the ankle, something else needs to be done in terms of forefoot sort of blood supply, regardless of what you do. And he has an absent PT as well. The only thing that I would do differently, or maybe this is what Dr. Bedi did, was that in these instances, I often find that the CO2, even with the angiodroid correct settings, never gives you a very good foot angiogram. So I tend to use like 2 or 3 mils of contrast diluted to 10, catheter inject it, and just wait. And that normally gives you a much better idea of what you're dealing with. That often helps. And then we tend to have a policy in our unit where we'll try antigrade first. Right. There is a stump of AT there. I think you can try antigrade first with no risk to the perineal. And then if that doesn't work, then absolutely, as Dr. Tarun said, I would do nothing different under ultrasound guidance. We like the micropuncture sheath, and we use a check flow to use at the end. And then exactly the same, a long 014 guide wire, try and retrograde rendezvous and try and do that. But yeah, so the only thing I would say is that I think 5 to 10 mils of contrast, even in a CKD patient, probably doesn't really change anything. Will give you a bit more of a picture of what you're dealing with in terms of the whole foot. And then we would definitely try antigrade first, especially when there's a stump like that, and then see how you go.
So I think you guys are absolutely brilliant. Yeah. You already laid out the roadmap. Anybody else would like to weigh in?
So let me invite Bao Tran. Bao, how would you do it in your center? How do you look at such cases?
So, yes, I agree with everything that's been said. Now, I'll say, I think after you angioplasty that perineal, your foot perfusion is going to get a lot better, and your image is going to get a lot better as well. So I think once you open up that lesion, you're going to get much better pictures about the collateral flow. We tend to, for this extensive of a disease, I agree, we would go, antegrade with a very low threshold to go retrograde. Just based on the angiosome, you really want to target the lateral plantar and really try and reconstruct the loop. But I think the imaging is going to get a lot better after you open up that perineal lesion. And then, going from I think antegrade is going to be difficult in this case. It's such a long lesion, going from a retrograde approach. I think you have a couple of different techniques. You can go either from, just directly puncture by ultrasound. You can puncture an occluded segment, using something like a Schmidt technique. Or alternatively, what I see is that some branches, some reasonably big branches from the perineal, and actually you can use that to cross over those collateral, find a straighter collateral from the perineal and use that to go retrograde back up through the AT and the PT if you don't want to do another puncture in the foot. So that's another option with, you know, a relatively floppy wire and a floppy 4 catheter with an 035 catheter supporting it. You know, I find that you can actually just go back up the perineal and re-enter through the true lumen retrograde through the collaterals, you know, to access the AT and the PT.
Bao, would you expand on the Schmidt technique? What did you mean by that?
So you know, on
benefit of,
ultrasound, you just puncture the you just use a micropuncture needle. You puncture through the artery, and under ultrasound, under external ultrasound, you're not going to see any you know, flash of blood under external ultrasound. You just wire it, so you visualize everything under external ultrasound. We use this a lot for you know, I think I don't know whether the technique Dr. Fadi and Dr. Mustafa over in Michigan, United States has you know, sort of pioneered this technique. But essentially the idea is that you just puncture an occluded artery and you wire an occluded artery, so you don't depend on the flow to access and you know, to get retrograde access. So that's the
you use
technique
a
we
hockey
use
stick, hockey stick probe for that?
I'm sorry?
I said you use a hockey stick probe for that?
Yes, exactly. So you have to use a very high definition ultrasound because you need to really visualize everything, both under transverse and longitudinal. Now I'm excited they have, you know, coming forward, they do have some 3D probes that are the size of hockey sticks, so you can actually visualize your needle coming in on a transverse as well as a longitudinal dimension. So you should be able to visualize it directly without switching the probe back and forth. But typically I would start with a transverse view, you know, watch the needle enter the artery and then switch over a longitudinal view to watch the wire going up. And you want to use, you know, a non-hydrophilic wire to get up.
Excellent. So can I invite Kaji to give her opinion? And do you plan your cases according to the angiosomes? And how would you address this one, Kaji? There to you.
So I don't think it's a very easy case, and I think really one of the questions is how much tissue are you left with after you've done the radical debridement. The assumption is that you will have at least a heel that is usable. With the patient being obese, whilst you've used a crossover technique, I think it's very difficult to get enough push using a crossover technique, and I think it's not unreasonable sometimes to consider puncturing the SFA even through the stent to try and give you a bit more push at that level. So our initial thoughts would be trying to do an antegrade approach. I think whilst the angiosome theory in principle is good, I think realistically what you want to do is try and improve as many of the vessels in a foot like this. So we would tackle the perineal origin stenosis first and then go for the AT, which it has a good stump more proximally. I think whilst an antegrade approach is usually our first line in our unit, I think more likely we would end up reverting to a pedal puncture, at which point probably use the AT as my first target in this patient. I also take on Andrew's point actually with CO2 angiography, and I think below the knee, the images that we get and into the foot are very poor, and also patients tend to get a lot of pain with using CO2 angiography. So unless you've got a popliteal block of patients under a general anaesthetic, we use contrast actually in small doses of contrast.
Thank you. And one last comment from Girish before we get back to Dr. Bedi for his.
I think everything is. I feel exactly what the rest have said. Angiography with contrast would be a better option with small amounts rather than doing CO2 when you're doing below the knee interventions. Other thing is, yes, when as Dr. Bao talked about if you are coming crossover, to try and come through the perineal and come retrograde would be a tough option. Whereas if you have come antegrade, but obviously he's not tried that because he's obese, plus he's got a stent in the SFA. So I would not be inclined to come antegrade from the same side. But the rest, everything is said. So as everybody said, that my first choice would be antegrade, and if I fail antegrade, then I would take a pedal puncture.
So the experts feel that the axis is your choice. You have chosen a right axis, and if it doesn't work, then probably we would go retrograde. And first, everybody suggests that we go after the peroneal, following which the anterior tibial looks like a good stump which can be accessed antegradely. So now let's see, Dr. Bedi,
So I think
over to you.
the main thing is, I think across the globe, the approach remains the same. So everyone, all of us are thinking exactly the same thing. We may speak in different languages or different things, but I guess we've all done the same thing, and this is what we did. And just to elaborate that this part of the BTK, we always prefer to do small contrast shot, as Andrew also remarked, and subsequently Dr. Sridharan also, that we would all like to use, we use those 2cc syringes, and you just need to give 1 ml of contrast, and that works very well. So these images are, I'm just going to run through this, and then I will come back again, because what are the things which happened out there? Because unfortunately, things don't really happen the way you plan them. So this was what Tarun remarked, that was the easy bit, going across into the PTA, and this is what we got. We did the PTA plasty, but we were not seeing much of forefoot, and as you can see, there's some
Peroneal.
Peroneal plasty.
Peroneal plasty, I'm sorry. Yeah. The peroneal plasty. So it did improve to some extent, but that was still not good enough. So this is where we went across into the ATA, and then we tried going across, but we were just not able to get across any access into the ATA. And then we go.
What were the wires and hardware that you were using?
So we were using a Command ES wire in this case. And this we had, we basically, by the time we tried retrograde also, and that is what happens, that when you look at these lesions and later, then you realize that, okay, what could you have done better? So this is where we had extravasation from down below. Up there, we were not really progressing. And after spending so much time of fluoroscopy, we decided to call it a day. So this is what happened. And then what we did was we discharged the patient in a stable condition. We debrided the wound out there and followed him up in the OPD. But unfortunately, every time we would debride the wound, we would get some bit of blood and all. But because of the Pseudomonas infection and the, the dieback which was happening, again, the patient used to deteriorate. One day you do a dressing, and next day again, it was back again to being black and blue. So that was the challenge which was there. And then we decided that especially the cultures constantly kept coming with Pseudomonas resistant to all antibiotics. So in spite of putting him on the best antibiotics available, he was just not responding. What he required probably was a combination of, one was, of course, trying to improve the perfusion to the foot, as well as wound management. We admitted the patient after a week, and we decided to do his dressings twice a day, one time with even acetic acid dressings and all, vinegar as we call it. And along with that, some other dressings and all, aggressive debrima. And at the same time, we decided to look up. The wound was just not improving, and we were getting peroneal was patent with biphasic flows, but ATA, PTA, we were not picking up. So then we decided that we will go back again and readdress this lesion that which we have not been able to address the previous time. So this is where we will, this is the angiography. As you can see, these are all DSA shots with contrast. And now you can see that the anterior tibial, the flow has improved into the anterior tibial as compared to the last time. You can see a little bit of contrast out there in the distal part of the ATA also. And now we again targeted the ATA, but still we were going down, we were a little better off. We ballooned up that part. But again, we reached a point of no return where the wire just would not cross in a calcification. So this is where we decided that we will have to go across, and as everybody remarked, and this time we were successful in terms of getting a wire across. We cannulated from retrograde, and as you can see, we were tickling. Both the wires were in the same plane. We took a Rubicon support catheter, and this is what we did. Then after that, we managed to get our wire on top and then floss the wire across into the sheath, the Balkan sheath, which is there. And then the wire was brought in, and then we reversed the wire. And then this is the finger which was there, which was basically holding onto the puncture side. We went across, pushed the balloon across, lost the access from that side. And now we have a 2 vessel runoff. And now we have basically the foot, and now you can see the foot perfusing reasonably well. Anybody would like to comment anything on this at this stage?
Dr. Bedi, excellent result. I think the only thing that I do differently is I'm a bit paranoid about reversing the wire. So I plasty everything until the very, very end. And then I come down with the Rubicon from the top, and then I reverse the wire and balloon tamponade at the very end as well. Because I'm so paranoid that it's so easy. We've all done it. Somebody might pull the wire, somebody might nudge me. Whereas when you've got a through and through wire, you're absolutely secure and you can just stay there forever and ever and ever and just keep plastering. So that's the only thing I personally would do differently in my practice.
Correct. Andrew, we have a wonderful team of people. So it's, when people are doing it, it's basically at least 2 or 3 of us are vascular surgeons. And then we have our trainees who are there, who are all second year and final year guys. So we generally don't expect them, and we are very, very particular about, going across. And what we do in this case is that we don't lose the Rubicon till we've got a wire across and cross the lesion out down below. And then after that, we pull out the Rubicon also. After that only, even sometimes we use a 4 French, micropuncture dilator. We use that most of the times, or we use a Rubicon, and we take it out only once we are through, because many a times you find that your wire gets exteriorized back into the catheter or the dilator. So that's what we do, that we just toggle it a little bit. And I think by and large, I think 95 out of 100 times you would probably get your wire across, because it's a hydrophilic wire that you're going with. So generally, if the part is patent down below, you will be able to find a 1 millimeter track of, taking a wire down there.
So this is
very nice.
Command wire or some other wire?
It was a Command ES wire. It was a Command ES, yeah.
Kaji, any comments on so far?
A very nice result. My only real question is, that's a long AT occlusion that you reopens up. I couldn't really see the outflow vessel. So in terms of durability, how much of a plantar arch was there left? And were you able to get a good result in terms of recanalizing that?
Yeah, Bao, I've seen some of your cases where you've been treating the plantar arches also. Would you go down and treat here also?
I think that you have such extensive wound down there. It's going to be hard to, I think your plantar arch is going to be very distorted. So I think at this point, the idea is you just try to get down as much flow as possible, recognizing that there's going to be distortion and there's going to be a lot of collaterals, going around the plantar arch.
Girish and Tarun?
You should write a review for be published on sclerotherapy.
I think what I would agree with Dr. Bedi, because withdrawing the wire gives you the access going into the plantar loop also. Because if you don't lose your wire from your pedal access, then you are limited to just the plasty till the level from where you entered. And as in this patient, we do require to increase the perfusion distally. And since initially we were not aware that how good is the distal perfusion, so sometimes, it's I think it's a good call to reverse the wire.
No, what Dr. Andrew was saying was that you plasty till you lead to plasty. Once you finish plasting, then at that point you can use a microcatheter, or you use your support catheter and go across, and then go down into the plantar aspect.
Yeah, so that's exactly. So sorry, then I just misunderstood.
I think many ways to skin a cat. It's like saying that, basically.
Yeah.
And the point is basically that, what you do is, once you have a wire across, you can lose your access, and at the same time, you don't need to do a manual compression of the puncture site. And once you get your balloon across, then you can just keep it inflated for about 2 to 3 minutes.
Guys.
So that helps us in terms of doing everything in one go.
Welcome to another session of Bedi Association of India.
So I think we are in 2 parallel webinars now suddenly. Yeah. So I think anything else that you would want to, you see, the problem is the challenge doesn't really end out there. The challenge is that you got, blood flow in the foot, but again, you got a terrible Pseudomonas infection, which is, still haunting you because it just refuses to die down. So should I continue further, Dr. Mathur?
So, Dr. Bedi, do you consider using drug-eluting balloons in such situations, or you are happy with just restoring blood flow and healing of the wound?
I think, these kind of critical limb ischemia kind of patients, you need very, very long balloons. And it is not really a great idea to, use drug-eluting balloons, because of the patient who's already got multiple comorbidities. You really require almost about 300 millimeters long balloons and all, or you will have to use multiple balloons. So I'm not really very, very, fond of using that. And the major challenges right now, two things. One is, of course, getting the blood flow. The second thing is addressing the infection which is there. So I think that was the more important part, and the patency of the whole thing. I would look at that. As long as the wound heals, my job is done. We are not looking at long-term patency of these wounds. We are of these lesions out there. We are only looking at getting the wound to heal. I think that is the end point in all these patients.
Any other opinions from our experts, Bao and Andrew, about drug-eluting balloons in below-knee?
Yeah, I typically don't use drug-eluting balloon in below the knee vessel. One thing I would add is, I often do image fairly routinely in the below the knee vessels. Sometimes you really could be surprised at how large of a balloon you can use to dilate. Sometimes I've used 4 millimeter balloons down a balloon below the knee vessel, just based on the IVUS imaging. And then the second thing that I like about IVUS is I like to do after, even though you've got excellent angiographic results, sometimes post-procedure for a wound like this, I may IVUS again and really, if there are spots of very severe dissection or recoil, I may place a short stent, a short DES or something like that, just to really, get that extra month or two of patency. We know this AT is going to go down. This AT is not going to be open for very, very long, but you just need it to be open for a few months. And I think if you can squeeze a little bit of extra time out of it, the little things like IVUS and addressing any small dissection or recoil, I think would be important.
Andrew, any comments? And Kaji?
I don't disagree with anything that's been said. I think the only problem that we all face is that, the wires that we've used are already quite expensive. IVUS is an additional cost. Spot stenting in the below the knee, we've got very limited choices to sort of the Science Prime, Synergy, the coronary stents, and suddenly the cost just keeps going up. Fortunately, in a government healthcare system, and we're a very rich country in Singapore, I don't have such limitations, but I am very conscious in a fee-for-service or in a poorer country, none of these things are possible. And so, as much as we would like to do all we can for our patient, there are financial constraints to how aggressive we can be in lower limb intervention. And that's just the nature of the beast, really.
Yeah. Kaji, any comments if you differ with any one of them?
I think, whilst I agree that there are financial constraints, I also think there's a significant cost associated with major amputation. And I think often in these patients, you need to be as aggressive as possible as soon as the patient presents. So I would throw everything at the patient that I thought was appropriate. In below-knee disease, I don't think there is a role for DCBs. I would, however, if there was recoil, use a drug-coated stent, typically the Science stent. So it is a very difficult patient, but I think if it needed stenting, then I would stent with the aim of getting tissue healing.
Great. Dr. Bedi, the rest of your story. Back to you.
So I think a couple of things. One is regarding the coronary use of stents and all. We do use them very, very occasionally, especially probably in the TP segment, which is there. Many a times you find that the lesion in the TP segment tends to keep on collapsing. And if you want to really get blood flow going out there, you can put in a coronary stent in those ones, because you have 3.5, 4 mm coronary stents available. Or the second one is when you have a very, very tight lesion, which is recoiling again after repeated ballooning. then you would consider, you know, putting in a coronary stent. But I think we have a very, very high threshold, I would say. And what we do all the time is, of course, which I couldn't show the images, which I don't have, unfortunately, is the eye flow images, as well as looking at the Doppler flows on table. And once we shift the patient out, the patient is, because we do our own Dopplers every time. So this patient is monitored round the clock. We do the Dopplers every day, at least about 3 to 4 times in a day. So see that how the patient is behaving, that the vessel is not really going down. And in this particular, case, fortunately, the one thing which was good was that the patient wasn't really, they were reasonably well affording, I would say. And they were very worried that they didn't want the foot to be lost. And they said, doctor, we'll rather stay in the hospital for as long as it takes till the time you get the wound to heal. So we spent the patient spent almost about 3 weeks in the hospital till we managed to get the wound to heal. And I will just move across to the pictures. So the wound was debrided. The bleeding was pretty decent out here, of course. And we still had to address the major, beast in the room, or the elephant in the room, which was Pseudomonas, because that just refuses to go. So one day we decided, after about a week or so of aggressive dressing, we just debrided the wound straight away. And then post that, we applied VAC. And then after a week or so, then we put him onto what we call the dermal replacement template, the IDRT, which is there, the dermal the dermal graft, which is there. We decided to apply that. And once we applied that, we had to put him on VAC for a couple of weeks. And this is the images of the IDRT, which has been, applied on the wound, and you got all those staples and all out here. But again, the challenge still continues. When we opened up after a week or so, we still found residual infection again, and a part of the IDRT was taken. The rest of it was, again, it had gone. So again, going back again to the grassroots and opening up, the good part was that the wound was, the vascularity was still maintained. The ATA was flowing very well. There's a good bleeding. And again, we got this dirty kind of pus out there. So we kept him on IV antibiotics all this time. The grade 2, of course, we had to remove, because that was, the tip was already showing dry gangrene, and there was, still some muck around the base of the grade 2. But then after that, we put him on to Veraflow with VAC and using colistin. That was done about 3 times. The wound gradually improved. Finally, we got the wound to heal. And this patient was taken up for skin grafting. After about 10 days of the skin grafting, this is what the wound looks like. The graft is well taken completely. The only challenge was that there was a heel part which was still undermined. So there was a cavity which was there below the heel. The vascularity was good, but fortunately there was no infection. But now the next thing was to just get that heel to stick out there completely. And that is what we managed within a few, every third day we were doing a dressing, took some lateral incisions and got this heel to, and asked the patient to walk. Once we got the patient to walk, within a week, there's a miraculous improvement. And this is the patient now, as it stands right now. This is just a video of today. He is walking now. For the last 10 days, he's been walking. No dressing of the wound, just basically keeping it covered. And as you can see, that this is what the condition is. The wound has healed completely. And this patient, who came absolutely on a stretcher kind of a thing and very badly infected, infection has gone. The good part is his creatinine is back to normal. Counts have come down to normal. All the parameters and all have reversed. So this is what my case was. And I think what's very important is that only addressing the inflow disease does not really heal the wound. We need to go, I think all of us have agreed to the fact that it is not really only the proximal part, but we need to tackle the distal part, and as distal as you can go. We talk about angiosomes, of course, we talk about the choke vessels which are there, and so many things. So we would want basically the blood flow to reach to the distalmost point. And BTK disease especially, it's not easy to manage with especially so much of calcification in our subset of patients. We have a very, very high calcium score in our patients. Literally, you don't need a roadmap with these patients. And you just look at the calcification and see that you're going in the middle of the calcification and not really going out. So you don't need to take too many angio shots also. And targeted BTK plasty is named to restore, so that at least we get some bit of wound blush, as we would call it. And another thing is that never shy away from taking a second chance. As in this case, on a particular day, we were not successful in doing that. You feel a little disheartened at that stage. But then we decided that we will go back after a week and decide. And I think patient's final expectation is wound closure, because the family was so distraught about him having to undergo an amputation in spite of the best treatment. And this is what we were able to achieve, that wound management, like I said, that just there are two parts of the whole thing. And when we look at the Wi-Fi classification also, we look at the two components. One is the wound infection, which is there, and the wound ischemia and the foot infection. So here managing there were two challenges which were there. And we were able to finally succeed in, getting this patient to walk back home without losing his leg. So with this, I will stop out here. And this is my wonderful team out here at Sir Gangaram Hospital. These are all my consultants there with me. And that's why I said that I have a very vibrant team out here, and we all work together. Thank you very much.
That was a great case, and the outcome is excellent, because it didn't look like we are going to get so successful towards the end. So we'll take comments, and in the meantime, there has been some discussion on the chat box also, and Dr. R.D. Yadav has informed that we have, in case there is a lot of elastic recoil in the vessels, we have some very long coronary stents, tapered coronary stents from the Merrill company. So that is one discussion, and the other discussion is going on of absorbable stents, which of course initially have not been very successful in the coronaries because of the bulky nature and stent thrombosis. So they were withdrawn by the Abbott. That was the absorb stent. And so any comments from our experts, Kaji and Bao, on these issues?
Yeah, I've used the the absorb stent, and I would say they're not very good stents. They are really quite bulky. They're hard to deliver, and you really have to prep a lesion just meticulously in the coronary to really get good results. So I don't think that generation stent would be applicable for below the knee, because what I find in the below the knee vessel is that, if anything, you're dealing with longer vessels, you're dealing with more calcification, you're dealing with much higher burden of disease. Now in the chat box, there's talk about the newer generation bioresorbable stent. I'm not familiar with any data, so if anyone's familiar, I'd be happy to hear.
Yeah, so there is this Indian stent called the Mires stent, which is less than 100 micron in the strut thickness. And the initial trials have been done in the first 100 case in patients with a good follow-up imaging, and everything was done, which showed excellent results. Unfortunately, a lot of things have happened after that. This was also the time when absorb was stopped, withdrawn. And then the other thing is that the Indian government came down crashing on the stent prices. So there were a lot of regulatory issues going on. But this stent is now getting evaluated and showing good initial results. Well, we'll see so many other options. Absorbable stents are a very important direction where everybody will move in the coronaries, and maybe below knee interventions. So this was an excellent case, and now it's open for discussion.
I can just make a point.
Yes, Dr. Bedi.
Yeah, so just to say that, using long stents, unfortunately, the stents in the peripheral circulation, especially in the BTK segment, don't behave the same way that they do in the coronaries. So I think one is, of course, you have much lower flow of blood flow out there. And with the kind of disease that you have, those dense calcifications and all, the chances of these stents going down are very high. So one would rather, look at doing POBAs, and even the results of DCBs also have not really been remarkable, I would say, especially in patient with such a bad, tissue loss which is there. So that's why I would be very, very chary about using both the long stents also, as well as even considering the DCBs also in these kind of situations. You may have to go in again and probably do an angioplasty sometimes in case required, but at the same time, leaving that hardware behind is again a major challenge, I would say.
So in those very hard, non-dilatable lesions in the below knee vessels, do you see any role for IVL, that is the intravascular lithotripsy? Because we have these balloons available for the coronary vasculature, but I'm not aware of below knee experience.
The challenge in the BTK circulation is you don't have IVL in smaller sizes. The smallest size that you have of IVL is 3.5 millimeters.
Yeah, no, in the coronaries we have.
But it doesn't go down. In our case, we will not get that length which is there, so that's the challenge that you will really have to, by the time you start using IVL, you will run out of steam very fast, because you'll need to have about 3 to 4 IVLs balloons at the same time, because you can only take 40 pulses in that one. So if you're going to be doing it in the entire
80,
segment
80
out
pulses,
there,
80 pulses for the coronary balloons.
Yeah.
And
So I would say the peripheral, I don't know if it's available there, but the peripheral IVL is now available in the 2.5 millimeter size in our lab.
Yes, with longer balloons, right?
What I typically use is that, I use it in spot cases. I've moved away actually a lot from I used to do a lot of atherectomy, CSI primarily, or to save money, rotablator is a lot cheaper for us than CSI, so rotablator as well. But what I found is that we go subintimal so often in the below the knee space that atherectomy it's just not as effective. So I've moved to IVL, and IVL. I use IVUS in adjunct with IVL now, with Andrew, circling back to what Andrew was saying, in resource poor settings that may not applicable, but in opposite in the US where it's really excess, I would say, the technology is developed us. So I often use IVUS to find area of dense calcification that I'll use IVL in. And I'll use IVL in that setting. If you don't want to leave stents behind, a lot of hardware behind, another technology that's new is the TAC technology. So that's a small self-expanding nitinol ring, I would say. It's almost like a stent. The device comes in sort of a delivery catheter, and you can drop, a very short segment of a nitinol self-expanding. It comes in one size, below the knee, above the knee, and you just drop it in, and it provides you a short segment of self-expanding, support platform, so to leave a minimal amount of metal behind. And then the last piece of technology I'll highlight, that may be reasonable for that case is, something called the FlowMet from Medtronic, which is a device where you it's almost like a pulse oximeter, but it connects to the, you would attach to the great toe in this case, and you would continuously check flow down the foot. And as you're going with the procedure, you can see your flow going up, and then that can help make a determination of when to sort of stop when you have adequate flow downstream. So those are, if costs were not an issue, those are all the technologies that we have available. But certainly, I think there's a lot of studies that need to be done about cost-benefit analysis, about how effective these therapies are, and they're fun to play with. But certainly, a TAC stent, I think, is about $5,000-$6,000. IVUS is has its own cost. So all of these devices are really quite expensive, and it depends on the setting that you're working in.
So can we have a short discussion on wire escalation in these totally occluded vessels? So when like Dr. Bedi, you started with a command wire, and then you find difficulty. So how does a person who's starting his procedures learn about the hardware? So can we have a short discussion on that? Yeah.
So our approach standard, especially in BTK segment, is that we prefer to use the command ES, which is an extra support wire, which is a good wire. And many a times, of course, what happens is when you're trying to go through a real, plaque of hard calcium, blob which is there, many a times it becomes very difficult because the hydrophilic coating of the wire and all tends to go off after some time. So that is where probably you need to use a weighted wire in those situations. So using a WIN 40 or a WIN 80 wire in those kind of situations to cross the lesion. But once you're able to cross the lesion, then it's probably better to go back again to the command ES wire. In the BTK system, we have used the V14 and the V18 also. A lot of us are using that, but so far I think we are very, very comfortable using the command ES, or in certain situations using the WIN 40 or a WIN 80. So that is what my take would be. Probably other people have experience with different wires.
Yeah. So, Kaji, what kind of hardware are we
A
using?
lot of stuff we don't get in India, unfortunately.
Yeah, everywhere. So that's the basic idea. We need to get a feel of things.
So normally I would go with either an 014 or 018 Advantage wire, which is quite a nice starting wire with either CXI or a Trailblazer as a support catheter.
Which company
And then it's a Trumo Advantage wire, which is it's a nice workhorse with a nice floppy tip. I like the Abbott Command wire, that's a good wire as well, but I think the problem really is with calcification. If you can't quite cross that lesion, then I'd slowly work my way up into those weighted wires. CTO wires, I'm not necessarily a fan of. I think it's very easy with especially the Asahi Stato wires, which I've tried a few times, and it's very easy to perforate, especially if you've got a long calcified lesion. So my go-to really is the 014 or 018 Advantages below the knee, and then go for a Command or a weighted wire.
Andrew, how about you? Do you have similar hardware that we use?
Dr. Bedi and I he's clearly a man after my own heart. I use an 014 normal and an 014 ES de-rigger for below the knee straight away. I tend to be quite a Boston diehard fan, so I'm a big 014 Rubicon person to follow up. If I need to, I'll follow up with a CXI or a CXC, depending on lengths and things like that. If I encounter the calcium, I do use the Win, but I like the Victory system. I think the Victory wires, I mean, they're very, very similar, I have to say, you know, in terms of tip weight and in terms of performance, but I've had quite good success with the Victory. I think Kaji's point about using these sort of heavy tip CTO wires and perforation is very well made. And I think the way I encourage my juniors to do CTOs is to go exceptionally slowly with those wires. It's not a stabbing motion. It's kind of a very gentle, you know, wiggle the wire and gently pass it up and let the wire do all the work. And I think then if you're going to use a slightly heavier weighted tip, then it probably means that you sort of decrease that risk of perforation, but that risk is nonetheless still there. Aside from that, I think it's very much similar to what everybody else has said.
I think, Girish, you have a similar wire strategy, isn't it? Girish, you are muted. We are not able to hear you. Sorry. Yeah.
Sorry.
Yeah.
Basically, we use the same technique, but sometimes we even use a micro catheter and try and go across with a micro catheter and then exchange for a support wire and then do the angioplasty. But to cross, especially these lesions, it can be difficult. And sometimes with a micro catheter, it makes life much easier.
So in the coronaries, we sometimes make a loop and try and deliberately go subintimal to cross the CTOs. So is this a primary target here also in the below knee?
Not primary, but I think what we would do is we would try and go with the tip without a loop and try and do it without some interval plane. But in case we cannot manage because of this high grade calcium, then we can try that.
I think loop in the BTK segment is better avoided. I think Girish would agree, because loop can be dangerous because then you are progressing the dissection. In case you are not in the true lumen, then you can really make the dissection look very bad afterwards.
And,
so
and the other thing
is,
the
BTK is not really SFA and all. You can go with a loop and all, probably even popliteal. But below that, to go with a loop is sometimes it can be absolutely.
No, we've done that. But when there is calcium, I would not advise you to do that.
Exactly.
Because calcium is the.
It'll just break away and it will just shear off the entire thing.
Then the calcium will deflect the vessel out, the wire out of the vessel.
Yeah.
Okay, then a final word on the complications each one of you has faced doing a BTK, and how did you manage them? So should we start with Andrew? How would you like to warn people? What kind of a mess sometimes you could get into?
Oh God, I you know, the more you do, the more complications you get. I think I've had everything.
I agree on that. That's why I asked you first.
I'll be totally honest. I've done everything. I've done everything that you could care to mention. I've occluded everything. I've perforated it. I've ruptured it. I think most of the time, you know, you will always find a way to bail yourself out eventually. And, you know, I think for specific things, we could probably have a better discussion about it. I can quite safely say I've done it all. I've quite safely say that, you know, having wire access is key to saving yourself. And that's maybe why I'm extra paranoid about these things. Oh, the only thing I would say though is I use a liberal amount of GTN below the knee. I use quite a lot of GTN. I do what the cardiologists do as well. I use a little bit of verapamil as well. I think it really does make a difference, particularly when you're dealing with these vessels. They're so prone to spasm, you know, we're a cardiac unit as well, so we have an ACT machine. So I've got no qualms about just sending off some blood from the sheath and just regularly checking an ACT and making sure that we're suitably anticoagulated, because as you all know and agree, you know,
how much would you keep the ACT?
Well, I only start checking it once I know that I've gone over 2 hours. Really, that's really the thing. So I normally just give a bolus of 5,000 and just start. But if we're getting to the 2 hour period and I think, hang on a minute, this is getting a bit thing, I just use an ACT to, number one, just try and decide how far I am into the operation and how far I think I need to go, and then maybe give an additional bolus. So that's kind of how I use it. But yeah, wire access is key. Generous amounts of anticoagulation, some antispasmodics, and, you know, just pray really, because these are horrible cases, and they everything that can go wrong will go wrong on the day you don't want them to.
So Bao, what about you? Have you ruptured arteries and how did you fix them?
Yeah, if Dr. Mathur, if I can add one
more.
Yeah. Because one is basically how many people would consider using an embolic protection device in these situations. I think that's something which is you can add on to, because you are the expert in that one. Maybe
but these,
add on that question.
No, embolism, distal embolism is a very important concern in these vessels, but the embolic protection devices are very tiny, of this tiny size may not be very effective and available. So I think that's a handicap.
A lot of people are using it. I think Girish has experience and probably Tarun
yes,
also.
And then let's ask Girish, what would he do?
No, normally I would not use it in the tibials. But yes, if I'm doing it higher up, say it's the SFA or popliteal, and if I have a single vessel run up, then I would think of using a protection device. But otherwise, I will not use a protection device routine. The other thing is that,
so if you're retrograde access, one thing I used to do when I was doing a lot of atherectomy below the knee is that you can just open up your sheath while you're doing atherectomy.
That's correct.
So, you know, once
so that's like a protection device for you.
Yeah, exactly. So that's why I do, you know, I try to, my threshold for crossing, for going to retrograde, going pedo is very low because, you know, these days, because I think our ultrasound technology is better and you know, the experience in our lab, we prep all the foot, you know, even before getting the patients on the table so that the decision, you know, there's not that sort of push to delay to swap over to retrograde. So I think for, you know, there's no filter that's small enough, but usually I would have a retrograde sheath in, and you can just let it open and flush out whatever debris you have.
Yeah, that's a good point. Yeah.
What we are doing is that we are always infusing the sheath with heparinized saline throughout. So that prevents any thrombus, but worst enemy would be thrombus. Or worse still is that if you dislodged a plaque and it goes down, then you're in trouble. As far as perforations is concerned, you can give compression and stop it. But when you have a plaque or a thrombus, then you're in trouble. And that is what you have to be careful about.
And I think I have, you know, once these now penumbra is available, I think the fear of embolus has, distal emboli has become little less, because in case if it happens, then you can use the catheter and just suck it out in case if anything goes down.
But the worry is the cost then again, right?
It's still cheaper, you know,
yeah, you are just...
PTO catheter is still cheaper than the embolic protection device.
Okay.
Great. So, Kanji, how do you deal with your ruptured vessels? Do you use a tourniquet or do you try to coil them up? What are the differences?
No, so similar to Andrew, I've had most complications. Ruptures, I've had a few. I think the first line is inflate that balloon, prolonged balloon inflation over the site of rupture for 2 to 3 minutes. usually that fixes it.
At low pressure.
At low pressure.
Yeah.
That doesn't work. I tend to use a tourniquet. And I think the thing is, if you've ruptured a vessel and it doesn't flow into anything, usually it does stop. So usually, as I said, first line balloon, and if not, a tourniquet. That usually stops it.
Have you tried both? Like first, if you try the balloon, it doesn't work. Then you try the balloon with the tourniquet.
I've done both of those actually. In the time that I did those, it was a case where we had a deep vein arterialization case. It was a slightly different case. We actually, when left it, actually came back to it a little bit later, and because that vessel didn't flow into anything distally, did settle by the end of the case. So often with the tibials, you can get away with it because it is a diseased vessel with a very small perforation.
Just one more thing.
Yeah. I think one of those complications, if you do use the high pressure balloon in those vessels, if you have calcified vessels, the high pressure balloon often sounds like a good idea. The disadvantage is sometimes that calcium in the water just cracks the vessel and can cause that perforation.
Yeah, Andrew, you were saying.
Sorry, in the spirit of talking about spending money, there is always the ultimate bailout option of the papyrus biotronic covered stent, which you can use below the knee.
Yeah.
But that is just exceptionally expensive, as we all know. But it's always worth mentioning. If none of those measures work, if that thing is still bleeding and it's going to cause a problem, then there is that bailout option as well, which I have used.
Yeah. So in fact,
if it's not leading anywhere, then maybe you coil it or something. Is it?
But I think, Dr. Mathur, just to say that the covered coronary stent is probably the cheapest stent which is available in the market. It hardly costs in India. It just costs about 3,000 or 4,000 rupees.
No.
Yeah.
Where do you get them? Please tell me.
No. The problem is
there's one which is there. That's a very cheap one.
The government has put it in the uncovered. In the regular
the bare
metal stent.
No, the covered coronary stent is one by Abbott. But it is probably the cheapest one. Just check it out.
That is why
that's a Graft Master.
Graft Master, exactly.
No, but it's not cheap. It's very expensive. But unfortunately, at this time, the government has capped. So the Abbott is keeping them complimentary to most of the centers wherever they are.
No. You have to buy it now. Abbott will get it for you, but you have to buy it. The distributors will not supply.
Sorry.
I said it's 8,000 rupees. I thought it was cheaper anyway. But
no. It's quite
8,000 rupees is still very cheap.
Yeah, no, it's far more expensive, and I'm sorry I disclosed our arrangement with them. So please excuse me for this. And
I'm sorry to disclose my price with them.
So this has been an excellent discussion today, and we didn't realize how this hour has gone by. And any of us who wants to make a final comment before I thank you all, you're most welcome. And our international guests and our Indian experts. Rajiv, Bao, or Andrew, Girish.
I thank you for the invitation to join. It's always really interesting how, as you say, we find more similarities than differences, even though we're really all over the world. So it's really great to kind of see everyone's techniques and approaches.
Yeah, thank you so much for joining us, Bao. Thank you so much, Kanji, for joining us on such a short notice. And I knew you were on a long weekend, and so I just saw your reply in the mail at 2:30 in the night, so I jumped at it. And,
thank you very much for the invitation. Enjoyable.
Thank you. And Andrew, thank you so much for joining us from Singapore. And I think it's time for your dinner, and you're already, it must be ready on the table over there. Girish, thank you so much. This is a busy time. I'm seeing Dr. Vimal Someshwar. He's another expert in our country, and we didn't get enough time to chat with Vimal. Thank you so much, Tarun. And
thank you so much.
Yeah, and last but not the least, the master himself, Dr. Bedi, you've done an excellent case. And I could already see that after the 2 SFA plasties, this patient was looking far younger than what he came to me. And
you did a great job, so that's why I followed up on that part.
Not at all, but you have done an excellent job, because this was the more complex part of the procedure. And so a big hand for all of you. Thank you very much, and I hope everybody has benefited. I have learned a lot from all of you today.